Now we'll go back to some Q&A. I'm not sure how much time I've left, but I'll try to cover some of the questions that came in. So, Marina, I'll start with you, our genetic counselor. How do we counsel and facilitate family testing to identify at-risk family members?
Sometimes it's as easy as give your patient a letter that they can distribute with some information, because they can be a little bit self-conscious in explaining what's going on in the family to other family members. But sometimes it's more complex than that, where you have to think about your patient and your patient's family as a social network and try to find out, okay, well, what member in your family is really good at gathering health information from everyone, or which family member is really great at disseminating information, right? So that's the disseminator. And is Uncle Bob going to be a blocker? So he's going to withhold genetic information, and therefore his side of the family is never going to know. So help your family understand their dynamics, and see if there's anything you could do to help navigate that.
Yeah, well, I try to do that, but I don't have the charm that Marina has. So I think that also we need to put in the mix. So thank you, Marina. Now, Dr. Russell, this question is for you. We have a robust genetics department within our institution, but how do we facilitate coordination of care with our genetic colleagues?
I think the first question is to ask. The field of renal genetics is really exploding. And as you've heard today from all of our speakers, there's so many different parts to it and so many moving pieces. And I think genetics as a field has a lot of subspecialties within it, and a lot of people have interest in different parts of the field of genetics, but you never know until you ask. And that's exactly what Dr. Rastogi did. Recruited me as a new faculty and said, "Hey, are you interested in the kidneys?" And I said, "Sure." And we started a collaboration that's really grown. So it never hurts to ask. And Marina has been an amazing collaborator for me, and has really taken on a lot of these renal nephrology patients, and seeing them as genetic counseling only visits as well. So there is really a nice opportunity, I think, to collaborate with a geneticist, but also a genetic counselor, and get creative about ways to work together, and keeping that line of communication open is really important. So the first step is just to ask and see if you can get someone inspired and interested.
Great. Thank you. Thank you, Dr. Russell. And, we are so grateful. And for all the faculty here, especially the two of you at UCLA Health, has made such a big difference, and Dr. Wang. So thank you. Thank you so much. And talking about Dr. Wang, the next question is for you, Dr. Wang. As a pediatric nephrologist, can you comment on the importance of family counseling after a child's diagnosis, specifically counseling for family planning for future children?
Yes, that's a great question. It's very important. We work closely with our genetics colleagues and the genetic counselors in our institution, but it really is a multidisciplinary field where after diagnosis, they're not just for the extrarenal manifestations that can occur based on the diagnosis, but it's important for the family to really understand what is going on, the implications for family planning, for their future fertility, and it's really a team effort. It's important to get the kids diagnosed as early as possible, and it's really great that we have all these genetic tests that are now readily available to us. But right with the diagnosis, and even before the genetic test is actually done, I really recommend that all nephrologists and physicians have the geneticist involved and the genetics counselor involved initially at the outset, before you kind of get too deep into it.
Very good. And I think that goes back to teamwork and getting the right team. And it takes time to build a team. And we have that now at UCLA at least, and I'm sure we have at USC and UCSF as well. So Dr. Park, I think the next question is for you. How to counsel patients who are 18 years and younger with ADPKD or PKD in general?
Yeah, so as an adult nephrologist, I do not see patients who are under the age of 18, but I often have patients who have children who fall into that age category, or who may have children who are adult children, in the ages of early 20s, which is a different scenario. For individuals who have children under the age of 18, we generally do not recommend universal genetic testing for the sake of a diagnosis alone, simply because the diagnosis could be distressing, and there are no current management strategies that are specifically approved for individuals less than age 18. That said, understanding this diagnosis and keeping an eye out for health symptoms, including high blood pressure or kidney infections, blood in the urine, et cetera, are all really important reasons to have the children under the age of 18 of these affected patients to be monitored carefully. As in my first case that I presented today, the diagnosis of the patient's young daughter actually happened relatively soon after her own diagnosis, and was not sought out specifically, but happened to be coincidental because of other symptoms her daughter was having. So, certainly children under the age of 18 are diagnosed with autosomal dominant polycystic kidney disease, but use of genetic testing to make that diagnosis is not something that is recommended.
Great. Thank you.
And
Thank you so
can I
much.
add an
Absolutely.
exception too is for prenatal purposes. So that's sort of the one asterisk next to it all that
Totally. Thank you so much for saying that. And indeed, we do have, as we alluded to, in our institutions, we're lucky to have a team approach. So for sure, at our institution with genetic counseling support, genetic support, and with reproductive endocrine, we sometimes do pursue counseling about offspring for individuals whose children are not yet born / are not yet conceived. So I thank you so much for pointing that out, Dr. Russell.
Yeah. And thank you, Dr. Park, and thank you for leading this at UCSF, the Nephro-Genetics, and very much appreciated, and the collaboration between the two programs. Dr. Kazi, the next question is for you. And I think you did touch upon this in your presentation, but it came up again. The testing in potential living kidney donors. If you can just elaborate more on that.
Yes. So basically, what it really comes down to is after a thorough evaluation of the recipient, if we identify any particular etiology that might have an implication on the donor, we start out by doing an assessment of the genetic testing on the recipient, and then factor in the potential that might have in terms of inheritance, obviously if they are related. And again, it's not one particular, because the diseases are different, inheritance is different. We factor those in, but it's sort of like, and again, it's an evolving, as I showed you, most of the papers are just from 2 years ago or 3 years ago, at least in the transplant literature. So it's an evolution that we're trying to incorporate the best strategies on how best to do it for not just the living donor, but oftentimes an individual may not have received a transplant yet. It's part of the pre-transplant screening. But I do want to mention that it does happen when you find a diagnosis, whether it's just PKD, then oftentimes when I go back and ask them some additional history, they find out, oh yeah, my son did have. Yeah. So then I have printed out extra copies so they can, okay, give this to your son's nephrologist, so they can at least trigger off some sort of a mechanism, because you do kind of feel some sort of there's somebody out there that does not have a diagnosis. So I've actually printed out multiple hard copies oftentimes to give it to the recipient. But the bottom line is you sort of incorporate what the diagnosis is initially. Now, sometimes it does become challenging when it's a paired exchange program, and we don't know some of the thing and the logistics of that. But by and large, to keep it simple, it starts out by the recipient workers, and then a domino from that based on what we see in the final report.
No, thank you so much. And I'll also share my experience with living kidney donation, and I was a medical director for 15 years for the living donor program. And one of the challenges that really came up, you spoke about hematuria, you spoke about Alport, you spoke about, but if you look at the chances of a living donor after proper evaluation ending up on dialysis themselves is very minimal, but it's not zero, right? And if you look at the people who do need transplant themselves, majority of them actually have some family history. So I think, and the reason why I bring this up, I think Marina spoke about this, how to, there's a way to bring this out, right? I mean, just telling them we have to get tested is not, but why it's important. I use the word charm, but it's important that you're smiling the way you bring this up, and it's not a serious death sentence you're getting. But who do we test? The short answer is going to be you test almost everybody. We have 400 genes we can test for. But who would be the low-hanging fruits? And the low-hanging fruits would be patients that we don't know the diagnosis. And hypertension is not a diagnosis. And in a lot of patients, diabetes is not a diagnosis. And this is important because this can have, like you said, Dr. Kazi, in your presentation, very nicely, it could have implication on the recurrence of the disease. And I can share some examples that we had. But also if they have a living donor, most of them are related still, right? So I think not putting them at risk, but in the right setting, counseling, those are very important. So I think that's very important from my perspective, to make sure that living donors.
You're absolutely right. I mean, nobody wants to reduce the numbers of living donors. What we want to reduce is bring it as close to zero. It's like you mentioned, the risk is not zero, but what can we do to reduce the risk, even further? And not doing nothing without knowing it is not, because, as we know, the long-term follow-up is starting to evolve. It wasn't until a few years ago we were mandating long-term lab checks of donors. So we really don't know the true burden of what has happened to donors who have donated 40, 50 years ago. And we keep improving, reducing those, chances, incidence, prevalence of anybody that has ever donated to get a kidney, have to go back and require a kidney transplant. I have at least 2 patients that have ended up like that. They weren't transplanted at my institution, but these were donors who donated and now have either received a transplant or are on dialysis.
Yeah, and I think that's very, very important, because the other point that I do want to mention is, where does this testing fit in your algorithm, right? That's a question that always comes up. We are people who know about genetics. We specialize in this. We will test. When Alex came to me, the first thing I said, I don't know what glomerulocystic disease is, to be honest with you. It's just a bucket diagnosis, and let's do at least another testing. But we also have to pivot. We do go for kidney biopsies, right? I mean, so can we add a test prior to that? Because expense is, if it's not expensive, it's accessible, then can it fit into the algorithm? And I think that's one message that I would like people to take from this today is that where does this fit into the overall algorithm? And we always talk about cost, we talk about accessibility, how to read the test, but please do think about that. Would this fit into your algorithm? Especially if you don't know the cause, whether it be transplant, dialysis, CKD, does not matter. So thank you, Dr. Kazi, and thank you, everybody else. The next question, I think, is for me. What does the green ribbon stand for? I think everybody has a green ribbon. Alex, you want to take a crack on that before I ask you some more questions?
For kidney awareness.
Okay, very good. Pink ribbon, I tend to fly American Airlines, and they would have those napkins, and all that they have is a pink ribbon. They won't even say what this is for. And we think about pink ribbon as breast cancer. Kidney disease has mortality higher than some of the most common cancers, but we don't think about kidney disease because it's silent. You heard Alex's story that she was asymptomatic, and then she got a scratch. She went. So we have to keep that in mind. So green ribbon campaign. UCLA was one of the few centers that started that, along with UCSF and probably USC as well. Right, Dr. Kazi?
Yes.
Yes. Okay. You have a green ribbon too. So it's about kidney disease awareness. My last few questions are for Alex. First of all, Alex, thank you for sharing your story. It takes a lot of courage to do that, what you did. And you're an amazing speaker and an inspirer. I mean, I just even got some texts from people, my colleagues who were on, and they said, they had tears and they're inspired. But I know we're a bit over time. I'm sorry.
I said thank you for letting me.
And your parents. So these questions are for you, Alex. Can you expand on your lifestyle and the changes that you made? Because I think your GFR went up significantly.
Yeah. So one of the things that I didn't share was when all of this happened, the one question that kept coming to my mind was, what would happen if I woke up every single day and I asked myself, how am I going to show up for myself today? And I wrote down in the beginning of this all of the things that I needed to change in my lifestyle in order for me to show up at 100%, knowing that I wasn't feeling 100%. So just to expand on a couple of those, I knew that it was important, especially during quarantine, to get outside. Even though nobody wanted to be outside, I knew it was important for me to at least get outside for a walk to clear my mind. I was feeling I was overburdened with information that I was reading online and that I was getting from all my doctors, and I didn't really know what to do with it all. My poor parents were going through it as well. So I got outside. The other thing was I went vegan. So when I say that it was awful, it's because going vegan is not easy. Luckily for me, I had gotten off red meat about 3 years prior. So it was really the transition between chicken and fish, kind of getting off chicken and fish. And as back in the day, I used to lift heavy weights. You wouldn't think, but I did, and I loved it. And it was finding the balance between exercising like that and lifting heavy and supplementing your body with the proper amount of food, right? Nourishing your body with what you needed. So that was the biggest thing that I went through was trying to find understanding in all of that. And I didn't do a very good job, I have to be honest. And at times it felt like I was even harder on myself because I didn't understand. But I just kept saying to myself, this is the process, Alex. I would talk to my doctors and ask the questions, what is it that I need to be eating more of? I did my own research. I went and worked with DaVita a little bit to get some menu items. And those were the ways that I was showing up for myself. The other one was, which is a sad one, but a great one, is I stopped drinking. The question wasn't whether I should stop drinking or not. The question was, what would happen if I stopped drinking? Would I feel better? And I felt better. And so I was just, instead of being hard on myself and saying, I can't do this, I won't do this, I have to do it this way, I was posing it as, let's just try this. Let me pilot it. So I decided to go vegan. It ended up being instrumental for me. I decided to stop drinking. A lot of people asked why. It was an opportunity to share my story. It was an opportunity to just focus on the unknowns or the things that people just don't know and they don't ask. So I took something that was extremely overwhelming and challenging, and I made it an opportunity for growth for not only myself, but for others. So that's kind of how that lifestyle changed and what came from it.
And also it takes discipline.
Yeah.
We were at a fundraiser a few weeks ago, and names not taken, and there was no vegan food there.
Yeah.
And there was excellent food, but it wasn't vegan. We asked for vegan, you couldn't get it, but you didn't eat anything. It was so tempting to eat all that stuff, but you didn't, and I was watching you. So there was a lot of discipline over there. Thank you, Alex. There are a couple more questions. There are a lot of comments coming about how inspirational you are, and hope you spoke about, right? And that's very important. So this is coming from one of the physicians. How do I empower my patients to take control of their own kidney health? And I think you've already spoken about this, but if you can get just 2 sentences on that, that would be great.
Patient advocacy.
Yeah.
That would be my biggest push. In a very short 30 seconds, sometimes it can be, they're all incredibly smart, and yet one of the differentials is we just don't speak the same language. So if you can bring somebody in that can almost take what you're saying and put it into an easier way of understanding, plus with the story, it's more likely that the patient or the end user is going to latch on and move forward with it. So I would definitely push a patient advocate or somebody that really aligns with what it is that you're trying to have happen, and kind of meet the patient where they're at to hold space for that difficult conversation.
We need more patient advocates. That goes without saying, because I don't have kidney disease. I know about kidney disease and and we need people like you who can share their stories. So last question, and I know we are way over time. How do you, as a patient, know that you have the right doctor?
I tell everybody this. The moment I met Dr. Rastogi, he said to me, everything that we do here at UCLA and in the core program is done with love. And that is how I knew that I was with the right doctor.
Thank you. Thank you, Alex. And Alex, I just want to thank you on behalf of everybody, you and your parents, for coming on a Saturday and sharing your story. It's not easy to share stories, and you should be on a TED Talk. You know, this is I thought I was at a TED Talk, didn't you? Yeah. So I want to give a round of applause for Alex. Alex, thank you. Thank you so much. And I want to thank all my esteemed faculty. I learned so much. I'm very, very grateful that you came on a Saturday to share all this stuff. This is all getting recorded. It's going to go on, we'll send you the link, the registrants, but hopefully it's also go on YouTube and social media so everybody can benefit from that. So with that, I want to thank Natera and UCLA Core Kidney Program for putting this together. All my esteemed faculty here, thank you very much. And hopefully you found this useful, and we'll meet again soon. Thank you.